morning, everybody. It's a beautiful, bright, sunny day here, and it's a great pleasure once again to welcome you to our second last of the winter series of the PNA RCSI Collaborative. And this morning's presentation from Sheila Wickham and Angela Kochman is actually a follow-on to this tripartite series, culminating next Tuesday rather. Today, Sheila will be taking the lead in respect of this presentation, and it's in relation to chronic disease example, and the matters relation to diabetes and mental health. Once again, the PNA and the RCSI Collaborative is most, I suppose we're overwhelmed really with the response of this winter series, and it's huge enthusiasm around it, and there's a lot of talking around it, and I suppose that keeps us motivated into what we might produce next year. So without further ado, I'm going to pass you over to Catherine, who's going to do formal introductions from the RCSI. And once again, thanks to Anya Halligan, who works around in the background to keep us all online. So thank you, Anya. You're most welcome, Sheila and Angela, and the floor is yours, Catherine.
Oh, thank you, Aisling. Morning, everybody. And there's 17 of you on already, and there's more of you. I just see the numbers going up there. So thank you, Aisling. And as Aisling said, the second last day of our series. So hopefully we'll see more of you this time next week. And today we're concentrating on factors related to chronic disease, mental health and diabetes. So as Aisling said, we're delighted to welcome Dr. Sheila Wickham. And Sheila has a doctorate in nursing science, an MSc and a diploma in family planning, a diploma in diabetes. She's a fellow of the Faculty of Nursing and Midwifery, which is always wonderful for us. And she's a registered qualified nurse, a registered midwife and a registered nurse tutor. And she's an assistant professor lecturer in the School of Nursing, Psychotherapy and Community Health over in DCU. And she's joined by her colleague actually from the same school in DCU. And many of you will know her, long history in mental health nursing, Dr. Angela Kochman. Angela has her PhD, she's her MSc, BSc, and again, absolutely thrilled that she's a fellow of our faculty, and we're delighted that they will share their expertise and their knowledge with you today. So just to say very briefly in terms of the housekeeping, there's a sign-in sheet that will go up, a Microsoft Forms little link just to sign in your name. It just asks for your name and your email, and this is a 1.5 credits have been approved by the Nursing and Midwifery Board. We can't issue you a cert with the credits unless we know you're there. So just pop in your email for us. And the other thing we're going to ask you to do is use the chat function to pop in all your questions as we go through. And Sheila and Angela will manage those. And again, there'll be an opportunity for questions and indeed answers at the end. So enjoy this morning's session, and I'm handing over now to Sheila.
And good morning, everyone. Thank you very much, Catherine and Aisling. I'm delighted to welcome you here again this morning. Myself and Angela are very happy to share again with you. I know some of you have been here with us last week, and to those who weren't and are just starting this week, you're very welcome. Now I have a number of slides here. As Angela will tell you, I always have too many. A lot of these are just for information and I won't be focusing on them too much. I'm going to start off the session. Angela will take over for a little while, and then I'll come back to you and talk more about diabetes. Any questions and answers, we'd say put them up in the question and answer box. Angela will be monitoring that, and she will let me know what's coming up and what's happening. So we welcome questions and answers. We'll certainly have time at the end, but if there's anything in the interim, feel free to bring it to our attention. So to get started, just to go back a little about last week, we were talking about the increased rate and the high rate of death among people with mental health illness, and how a lot of this was due to physical things, such as chronic and the non-communicable diseases. There is a much higher incidence of these diseases among people with mental health illness, and we're going to focus today a little bit on those, but particularly on diabetes as an example. And then, as I say, we finish up with a question and answer session. So, as I say, this is what we find. All these factors contribute to the higher death rate and the much earlier death rate. And people with mental health illness are losing 15 to 25 years of their life, which is a considerable length of time to lose. And we can help to reduce this or indeed prevent it. And that's what these sessions are about, to try and make a difference. And as I was saying last week, if I only make a difference to one patient, look what that can achieve. Chronic disease, and we must remember, when I talk about chronic disease, mental health illness is another chronic disease. We talked about the definition, lasts for a long time, 3 months or more, with it usually can't be prevented by vaccines or indeed even cured by medication. Once you have it, we tend to have it for life, but we can manage it. And that's what we want to do with a lot of our both physical and mental health. You see it yourself in mental health. We can manage the chronic disease by medication. It's the same with a lot of the physical chronic diseases as well. But we need to identify them first, and then we need to treat them. The 4 main types, we've said cardiac disease, cancer, which is an interesting one. Very few people tend to consider that a chronic disease, but it actually is. People are much more inclined to live now with cancer, provided we can treat it. Chronic respiratory disease, which is secondary quite often at times to smoking, which again is much higher in your mental health population. And diabetes, which is one I will focus on. They talk about tobacco use, physical inactivity, unhealthy diet, and the harmful use of alcohol as increasing your risk of chronic or non-communicable diseases. And you think of those 4 factors, very high instance of all of them among those with mental health issues. We will see, no matter what we talk about transferable learning, and people with chronic disease tend to have the same problems about managing it, identifying it, having the motivation to manage it, having the knowledge to manage it. And it doesn't matter what chronic disease it is, whether it's a mental health issue or whether it's a physical issue such as diabetes. They're the same sort of problems, and that's what as nurses we need to work with them on. They can learn to take day-to-day responsibility for their illness, and that will vary. How much responsibility they can take and how long they can take it for will vary. We know that. We all have good days and bad days. But the more they can know and the more confidence we can give them will help improve their health status. And that's what we want to do. I always like this quote, it's chronic diseases are like wolves, they travel in packs. And the very fact we're talking about chronic disease among those, a population with mental health illness, it says it answers that in itself. Within Ireland, we have quite a problem, and that's one thing we can thank Tilda for. We do see it increases dramatically with age. It tends to be higher in the north and west parts of the island, which is interesting, lower in Dublin, more among men. And certainly by the time you're 65, most of them, over 65%, have it. As I say, we've identified the risk behaviours which contribute to it. And now I'm going to hand over to Angela, who'll talk a little bit about the literature, and then I will come back and focus particularly on diabetes. So Angela, you okay there?
I am here. Thank you very much, Sheila. Yes, I'm here. Good morning, everybody. My big question before I start talking to you is to engage with me and maybe let me know, do you currently have patients with type 2 diabetes on your caseload? Or if you're working in a hospital or in an acute unit, do you have many patients with type 2 diabetes in particular? You might just be able to say, yes, I do, or I have 5, or I have none. That would be useful. It would give me an idea of, you know, where you're coming from and how many you're actually looking after. That would be helpful, whether they're type 1s or type 2s. That would be really useful. And, you know, we can refer back to then any specific questions you have about diabetes in your patients or on your caseloads, just type them into the chat box. And as we go through, then I can put them up to Sheila and she'll be able to help us with the answers. Is that okay? Now, what I'm going to do now is just going to look at 3 articles. Now, you'll forgive me for looking at the literature, but I really have to, because I think all of our care has to be evidence-based. So I'm going to just refer to only 3 articles. But before I do that, I will have to say exactly what Sheila said. The problem with metabolic syndrome is huge in our population, up to 60% of our clients, and we said that last week. And we know that these problems are related to numerous things, like Sheila said. Bring it back to your patient. Don't think about the patient factors that contribute to their illness. Think about the illness factors, and also think about the medications that we have and the amount of problems we have with weight gain and lipids in their blood. So, you know, always think back that our client population with diabetes and comorbid mental illness have a lot of contributing factors, more so than the general population, and that's important. Now, the first article I'm going to refer to today is one that was published. It's on the next slide, Sheila. It's one that was published in the UK, okay, and it was by yeah, here we go. It's by authors in the University of London and Mulligan et al. Okay, and this is interesting to me because this looks at interviews with patients. We rarely get evidence from patients, from the actual patients themselves with severe mental illness, about how they manage their illness and their diabetes. So this one was important because there's not too many of these out there. So they were looking at the importance of self-management, how important it is. But they also find that a lot of the patients aren't able to do it. They weren't physically active, they weren't eating healthy diets, they were struggling with their diets, and because of that, you know, there was lots of self-management problems. And a lot of them admitted that when they're not well, they don't take their medication, their diabetic medication. So we get an insight there into the mental health overrules the physical health in this case. So because of that, we know that that's going to cause, you know, numerous problems for them. Yeah. So she went on the next slide to say, go on to Mulligan, next one, Sheila, for me.
Yeah.
No, I have another one. We'll leave Mulligan aside. I'm going on to another one from Denmark. Yeah, it's Denva. This one comes from Denmark, and interesting enough, the title says it all. It says they don't get into that. Okay, so they're saying mental health professionals have never mentioned my diabetes. Now, this is another qualitative study. This study has a few more in it than the last one. It has 15. The last one had 14. Sorry. Yeah, and it interviewed again these clients with severe mental illness, and it talked about how they manage their illness. And you know, again, the study is very clear on saying that there are huge risks for these patients because they have difficulty in managing it, and they're also advocating that nurses like us specialising in mental health care, they're saying we have a responsibility now to support our patients, to monitor their diabetic complications. Now, Sheila's going to talk about those later on in the morning, and to advocate to ensure that they get optimum care, because there are things we can do for them, because it's quite obvious from reading these papers that these clients are not able to manage their diabetes, their overall mental health is not allowing them to manage it well. On the next slide, it shows the themes that came out of this article. And there were 5 themes, and the interesting 5 themes, really good article, says that mental illness overshadows diabetic management. Now, you really have to keep that in your mind when you think of how many diabetic patients you have in your caseload or on your ward or in your hospital. It says mental state substantially influences diabetic care. Now, that's big one for us as well, because that means that, you know, they're maybe not always going to be able to manage it. They even say that the daily routines of diabetic care is challenging, very challenging for somebody with severe mental illness. Diabetes is very burdensome for them. And the last thing of all, which is the title of the paper, to say that mental health professionals never mentioned my diabetes, they just don't get into it. That's a big one as well. So dialogue with patients about their illness is what's really important here, that the nurse is able to have a dialogue with the patient. And in order to do that, again, the nurse needs to be very well informed themselves about advice and about how to good advice on self-management for our patients. So there's lots of things we can learn from these articles. If you're interested in having a look at them yourselves, I would definitely encourage you to look at the evidence, because this is the kind of evidence on which we base our practice. That's why we look at literature, and that's why we're kind of very keen to advocate this. And finally, this article does conclude by saying that the self-management for diabetes is complex. It's very complex for the general population. It's even more complex for somebody who's living with severe mental illness. And I know that Sheila will go back over this over her next 10 or 20 slides. Diabetes, again, they do say it's strongly influenced by the emotional and mental state of the patient and their ability to manage the daily routines. So that's important to remember. And they also do say that there is a need to give more support. We have to give more support in order to improve their self-management. If we don't, they will have massive complications. And we do know that the complications of diabetes can lead to premature death. So, you know, there's lots we can do. The findings of that particular study do say that there are tailored interventions that will support these people in managing their in their self-management of diabetes. And I think there's one more, and the next one is this is actually what we call a systematic review. So this is very good evidence because this is a review of a big lot of literature, and this systematic review looked at a very large number of papers, and the papers were all to do with people living with diabetes and the concerns they had about the illness. And there's some very good messages in there about what's important and what's not. But they're very similar to what was said in the Dutch paper and in the UK paper. They're very, very similar outcomes, and this one comes from Canada, by the way, but they're very, very same. They looked at people living with diabetes and their concerns. And they looked at the distress that had caused to the patient. They looked about the worry they had about insulin resistance and the fear they have of hypos. They have actually, a lot of patients have a fear of a hypoglycemic episode. So, you know, there's something that Sheila is going to talk about and explain more as she goes on. But these are things that I'm taking from the mental health literature and how important it is for us to understand how our patients feel and what they're enduring. So, you know, there are issues that we might be able to talk about further on as we go through the rest of the slides. Is that okay? I'm not sure the next one, Sheila, I can't see it, but okay. Robinson does talk about the distress of the diabetes. Thank you for that. The emotional burden of living with it, the distress of the self-management, whether it's insulin or whether it's medication. It has on its social relationships because you can't go out and eat the same as you would. You know, the effects it has on your patient-provider relationship, and then the worry they have about insulin resistance. They're all worried about ending up on insulin, and that's a huge concern to them because they're terrified of that, and the fear they have of being hypoglycemic, of a serious, especially at night, or the trauma that might have for themselves and their families. So that's the end of my slides. I will come back to you near the end when Sheila's finished, but don't forget to come back in on the chat box. Please let us know how many patients you're looking after with either type 1 or type 2 diabetes and what your problems or what you encounter in the care of the patients. Is that okay? Thanks for that. Sheila, you'll continue now with the slides.
Thanks very much.
You're welcome.
As I say, diabetes is a very common problem, and normally if I was physically in front of you, I'd ask you about that, and I'd say how many people know someone with diabetes, and everybody put up their hand. It's on the increase. We expect to have 690 million people by 2045, and the thing is, a lot of those will be patients with mental health issues, and we need to treat all the illnesses. I usually start by giving the definition of diabetes. If you ask somebody, and even in the nurses, they'd say, you know, your sugars are wrong. It's actually a lot more complicated than that. And this is the WHO definition. We've had it since '99. They haven't changed it since. And I've actually asked that Catherine put that link, make that link available to you for the diagnosis and classification article report. They talk about a metabolic disorder of multiple cause, characterized by high blood sugars with disturbances in carbohydrate, fat and protein metabolism, resulting from defects in insulin secretion, insulin action, or both. So it's a lot more complicated and complex than we'd actually think. It's not just a bit of sugar, as we tend to think. Sometimes it's very dramatic, and usually certainly type 1, which I'll talk about briefly. But you'll have dramatic side effects, very thirsty patient, losing weight, you couldn't miss it. But more often, particularly with type 2, symptoms are very not there, basically. People don't tend to notice them. There's a gradual onset, and people are saying, sure, I was getting old, I was a bit more tired, and that's it. They don't actually realise they're developing diabetes until it's picked up for some other reason or because they get complications. And that's an important thing to remember, because we as nurses have a responsibility to our patients to check for these things. We have the knowledge, so we should be doing it. The other thing I'd always stress is diabetes is a chronic disease, but it's progressive disease, and the requirements to manage it will change as time goes on. And that's not the patient's fault, which sometimes I believe they're made feel it is. And we have to remember it's not, it's just a progressive disease. As I say, there's mainly two types, type 1 and type 2. There is the gestational diabetes, and we talk about the maturity onset diabetes of the youth, the latent. I'm not going to go into those. It'll be type 1 or type 2, and indeed mostly type 2 you're going to come across in your work. To diagnose diabetes, and I touched on this last week and I mentioned again, you have to have a fasting blood glucose of 7 or above, a random of 11.1 or above, or 2 hours after a meal of 11.2. You have to have 2 of those. But the thing is, they are quite high. Now, we're always fussing about diagnosing people. You consider your patients, your cohort of patients. A number of them would be driving, they would be working, they might have mental health issues, but that doesn't stop them from having a relatively normal life. If I diagnose any of them with diabetes, that'll have insurance impact for their driving or things like that. If they drive public transport, they can't do it anymore. That you're not allowed to do that with diabetes. So I'd always say be very careful of a diagnosis of diabetes. Make sure it's an accurate diagnosis. It's very, very important. As I say, this one I touched on last week. This is for the people who aren't quite normal blood glucose, but they're not frank diabetes. And they're an important group because if you work with those, and we focus definitely a lot on those next week, the impaired glucose tolerance or impaired fasting glucose, we can actually delay the onset of diabetes. And that's something we would recommend. As I say, they're considered risk categories for developing it. And it does work if we do treat them, because obviously I don't want anyone with diabetes if I can avoid it. Diabetes treatment, we start with education, and you consider this for any chronic disease or so even mental health. What's the first thing you try and educate them? Educate them about their medications, about the disease itself. Healthy eating, regular exercise, and finally I will go to medications. It's not my first line of treatment. I don't rush in with tablets if I can avoid it. I'll always start with education. Type 1, which is the one people tend to talk about more and consider quite dramatic, usually occurs under 35. It can actually occur at any age. My oldest patient was 84 when she developed type 1. It happens, not commonly, but so bear that in mind. I'd always say the disease has never read the same books as I have. They usually, patients with developing type 1 will normally present with a very short history of symptoms that have been getting much, much worse very quickly. Severe thirst, weight falling off them, they have ketones in the urine. These patients always require insulin. It's an autoimmune disease. For some reason, their pancreas has destroyed their insulin-producing cells. You have to have about 90 to 95% of those cells gone before you'll actually become fully symptomatic. So therefore, these people need insulin. There's no insulin-producing cells. But it's only a very small minority of my patients. It's only 5 to 10% of them. And you bear that in mind, and it's probably reflected in your own cohort of patients. If you think how many patients you have with diabetes, how many of them actually have type 1 diabetes, and it's very much the minority, if you have any at all. Type 2, or as it used to be called, non-insulin dependent diabetes, it makes up 90 to 95% of my patients. And what normally happens, and we talk about insulin resistance, which Angela spoke about last week as part of our metabolic syndrome as well, starts with insulin resistance. And that means I'm producing insulin, but I'm not using it properly. And therefore my body tends to ask me to produce more. And then I get it, it's working harder and harder. So I'll eventually wear it out. Type 2 is normally associated with age, but that is changing. And that's why we have maturity onset diabetes of the young. And that's to do with our lifestyle. It's associated also with obesity and being overweight. If you have a family history, there is very dead. Now that can sometimes be more challenging to get from your patient mental health issues because they might be slightly removed from the family. They mightn't have known their grandparents or that as well. If you have a history of gestational diabetes or impaired glucose tolerance, if you're physically inactive, and certain races, we have one group of South American Indians who have a 90% incidence of type 2 diabetes. But we have the Afro-Caribbean has an increasing incidence of it, and we have an increasingly diverse community. So it's something to be conscious of now. We are seeing more type 2 diagnosed in adolescents and children, and you consider your group of patients, your cohort of patients with mental health issues. They tend to be physically inactive. They're not the healthiest eating habits, so you may see an increased incidence of type 2 at a younger age with those. And as I say, my African Americans, Hispanic, there's much more of those because of their ethnicity are more prone to developing type 2. So again, we're seeing a more diverse community be open to it. As I say, it's 2 to 5% of the population overall. And I always say this, if you have 100 patients in your cohort and you don't have a few number of people with diabetes, you're missing them. The thing is, people think, type 2, it's only a touch of diabetes. I'd always say it's like having a touch of pregnancy. You either have it or you don't. But the problem is, if you have diabetes and don't look after it, it is actually associated with a very high mortality rate, and to the extent within 10 to 15 years of being diagnosed. And that can be a problem. So it's important we diagnose it and we treat it. Weight gain and physical inactivity are important factors in the disease. And this is where back to Angela was talking about diagnostic overshadowing. So I have a patient who has serious mental health issues and also has diabetes. And I'm looking at their medication, and I favour the medication, the psychotropic medication, which perhaps will not serve the diabetes well. So they put on more weight and they'll be more physically inactive. So therefore, okay, I might get their mental health issues under control, but I possibly will exacerbate their diabetes. And that's what we have to be careful of. We need to look at the whole picture with these. Certainly if people present to you and they have a family history of diabetes, if they're over 65, if they have a history of gestational diabetes, or indeed certain medications such as the antipsychotics, such as steroids, then they're more likely to it. Now the thing is, it can be very, very challenging treating diabetes. It's not as simple. As Angela highlighted that about the problems with hyperglycemia and such like. And when I'm treating a number of illnesses, such as a mental health issue and their diabetes, it just adds complexity. So keep that in mind. And it's a case of making sure it's a balance, and it's quite a complex balance to get right. We require lifestyle modifications with type 2 diabetes, and we are happy to educate about them. But it's quite hard when I've mental health issues to understand that and perhaps to take it on board. And we all have bad days. People with mental health issues may have a few extra. So bear that in mind. It's to keep them motivated or remotivate them at times. And it's important that we can do that. As we talk about education, and that's always has to be to the right education for the right patient, what they can take in. Healthy eating and a healthy lifestyle. And we encourage that. If that doesn't work for the type 2, then I can add in some oral medications. And if that's not working, I can use insulin as well. Now, people talk about the fear of insulin. It's quite interesting to see a lot of the fear, and I've worked with endocrinologists, diabetologists, they don't want to put the patient on insulin because the patient won't like it. This is something, who has the fear? Us as a healthcare workers or the actual patient? Because I always remember one particular patient who hadn't been exactly rushing to go, and I put her, I ended up having to put her on insulin, which she went on. And she said, God, I feel so much better, she said. It's like a new lease of life. I wish I'd done this years ago. And it's something we have to be careful of, that we don't let our own prejudices get in the way, perhaps. Patients can manage with insulin. We don't talk about, they're not going to be insulin dependent, they're going to be insulin requiring if they're type 2s who need it. But don't let your hang-ups or indeed the medic's hang-ups get in the way of treatment. Sometimes the reward the patient gets from the quality of life is worth it. As I say, we talk about education. Now, Angela said how the nurses didn't even mention the diabetes.
No. The
thing about diabetes care, and we'll always emphasize this, it's a team approach. The center of the team is the actual patient. And after that, we'll have the nurse, the doctor, we have the ophthalmologist because of the complications, we have the chiropodist, podiatrist, we have the dietitian, we have a psychologist, and in your case, mental health patients, a psychiatrist. So it's quite a big team event. But the thing is, if the whole team don't sing from the same hymn sheet, then it's not going to work. I need to make sure that if I meet a patient with mental health issues and I talk about it, that the nurse, when they go back into their community setting or whatever, will go, and what was the nurse saying, or the nurse, diabetes nurse specialist saying about the diabetes? That you're emphasizing it, and even little things like that can make a difference to the patient. And I keep saying it gives them a sense of control over their illness and a sense of ownership, and responsibility. when we talk about education, the first thing we always say is tailor it to the individual needs, because obviously how I'd educate an 18-year-old is going to be different from how I educate my 80-year-old. So I'll have to tailor it that way. They have different needs and requirements and what they need to know. And also you have to tailor it to what they can take. If they're going through a mental health crisis, maybe they won't be able to take as much in as I'd like them to take it in. So maybe I won't give them too much information then. And we always say, remember, you retain about 10% of what you get in an education session. So I have to keep re-educating, and that's something to remember always. I'm a great believer in explaining diabetes. If I explain what it is and how it works, and that it's not one, it's not their fault they have it, and that it is a chronic illness and a progressive illness, and the importance of looking after it, I tend to get much more buy-in. I'd always say that if I tell you to do something now, if I tell you to go and get a book or a dictionary, you might probably might do it, mightn't do it. If I tell you go and get your nurse's dictionary now because I want you to look up at it, even that I'd have much more sense of buy-in. So it's just explain the illness, give them a sense of ownership of it and why it's important. Self-monitoring. We don't live with our patients 24/7 by and large, so it's important that they can monitor their own diabetes. It's a 24/7 illness, by the way. It's there 365 days a year. So it's important that the patients themselves can monitor, because that's how they contribute to the team management of the whole disease. We're also very believer, I can tell them to monitor, and I've seen this happening. Make sure you monitor, do your blood tests. We don't do urine tests anymore, really. It's all blood testing. And we tell them, and then we don't tell them, well, what to look for. We generally talk, we like your sugars between 4 and 10. 4 is the floor. Anything above 10, I don't want it too often. And that's what we sort of aim from, and that's good control. Now, I never get excited. A patient rings me and they go, and they would happen, so I have a sugar of 18. That's grand. And I'd say, what happened? And they'll go, well, I met the daughter for a cup of coffee this morning, and sure, that's grand. I don't get excited. You just tell them to recheck in a few hours and see where it goes. And that's the thing, that they know what good control is. And that's, again, within their capabilities, because some patients are much better at this than others. I just put this one in briefly because intercurrent illness and diabetes, quite often patients will be managing their diabetes quite well, but some other illness, it could be something as simple as a sore throat or a cold, or indeed a mental health crisis, that will upset their diabetes control. And the thing is, if that's the reason for it, explain that to them. That will upset their diabetes, and it's not their fault. It happens. Hypoglycemia, and I've put this here specifically. As I said, 4 is the floor, 5 to drive. There are rules, and we get more excited about hypoglycemia than we do about anything else. And I'll talk more about that as I move to onto the complications. Advice about hypoglycemic agents, very, very important. There are certain medications you have to take with food for type 2 diabetes. Now, if you don't explain that to the patient, and I never mind the patients, I've had problems with that up the wards. It had to be taken with meals. And we put a patient on this. It was an enzyme inhibitor that it works to start the gut, but you only release the enzyme when you eat. Now, the thing is, the patient was getting the tablets at 10, 2, and 6. You don't get fed in a hospital at 10, 2, and 6. Tablets weren't working. So, and that was, as I say, within the healthcare setting. So, same applies to the patients. None of us are that good about reading the information. So we have a responsibility as well to check when they do know something about it. Complications of the latter part of the lectures on this, so I'll go into them at that stage. The social and legal implications of diabetes. People with mental health issues, you would have a population who are among the homeless. You would have a population among who have addiction issues. Now, if I then hand them, albeit a very pretty pen now, but I'm still handing them needles, pens, that may have, they mightn't be involved, they mightn't have addiction issues or whatever, or they may have had them and now they're clean. So the last thing they want to be seeing is shooting up. You know, the whole idea of if you are socially interactive with people and they go, excuse me, I've got to go and check my blood sugar, that may be too much. There may be something they're not comfortable doing. You know, and particularly if I have a mental health issue, I'm conscious enough of that. Now I'm going to be running off to check blood sugars as well, or take injections. what are the implications of that? So bear that in mind. It has, and just because I mightn't see it as a problem doesn't mean my patient doesn't. Preconception advice. This is very, very important. As I say, we're increasingly seeing people, particularly with type 2 diabetes at a younger age, in their 30s, late 30s, even 40s. Now, the thing is, I am a midwife, as I said earlier, every pregnancy should be planned. And that applies to all of us, never mind people with diabetes. Ideally, you should be at your healthiest. You shouldn't be drinking or smoking or taking any over-the-counter medications or any other medications before you get pregnant in an ideal world, and you should plan when you get pregnant. If you have diabetes, it's even more important, because I want your control as good as possible. The other problem, particularly with type 2 diabetes, is some of the diabetic medications that we use are tetragenic and would not be used in the first 12 weeks of pregnancy. In fact, we put you straight on insulin. The thing is, people have a habit of forgetting they can get pregnant. And I remember one lady I had, and I was, you know, she had been diagnosed with type 2, lovely woman, she had 2 kids, they were well in their teens. Well, this was during the leading circle. And I was giving her the advice, and I said, and what about, you know, contraception? And she looked at me, and I said, yeah, to prevent me. Ash, I'm well past that, nurse. And no, you're not, basically. I had the eldest I delivered when I was doing midwifery, we had a 48-year-old delivered a baby, perfectly natural. She had married late, they'd adopted 3 kids. She started having kids at 44, and this was her 3rd. They'd adopted 3, this was her 3rd. She was hoping this was her last of 48. So, you know, it can happen. And particularly bear in mind, if somebody has been unwell because they've had diabetes for a number of years, and all of a sudden they're being treated, their blood sugars are under control, there's a better chance of them getting pregnant. Now, your patients with mental health issues, some of them will be on long-term conception, but not necessarily all of them. And again, it's the diagnostic overshadowing. You know, they've their mental health issues. Now I've got their chronic illness or diabetes. Do I remember to ask about contraception? It's very, very important. And I couldn't stress it enough. Identification. They need to carry a card or wear a disc or something that will allow people to identify that they have diabetes. If you turn up unconscious in A&E because of hypoglycemia or that, people won't think diabetes first, particularly if you have a mental health issue and mental health medications. So make sure they wear it. Diabetes Ireland is a patient organisation, and it has a professional section as well. So you as nurses are welcome to join. They have good study days. You can look them up on the web. They're quite easy to access. And then diet and healthy eating. And that's what I'm going to talk about next. We prefer to talk about healthy eating more than diet as such. And there's a few simple things we'd say. Avoid being overweight. That's the first thing. None of us should be overweight. And we would encourage people to get to a healthy weight. Now, the thing is, some of our patients, and because they're on their psychotropic medications, might be very overweight. So be realistic with what you can encourage them to do. Eat regular meals. This is quite an interesting one. People say, oh, you told me to lose weight, so I stopped eating. One, your medication is going to work. It's going to work whether you eat or don't eat. If you don't eat, there's nothing for it to work on, and you will probably go hypoglycemic. Not with all of them, but with a number of them. The other thing we have found is that eating regular meals tends to reduce the need to snack, and that tends to stop people. And I've had patients do that with patients who I get on insulin later in life. They'll go, I'm eating more than ever, and I'm losing weight. And they're not eating more than ever, but because they're eating regularly, they're not snacking. That's a big difference. Eat more high fiber carbohydrate. Carbohydrate is the fuel for us in our bodies. It's what we use for energy. But we want you, particularly if you have diabetes, to eat more complex carbohydrates. So it takes a bit longer for you to digest it, so your body can cope with it better. Eat less sugar. And you'll note, I don't say no sugar. We encourage our patients to have a healthy diet. We encourage them to eat fruit and vegetables, preferably not grapes and strawberries, but we will encourage them to eat fruit and vegetables. There's sugar in all those. You can't avoid sugar. There's sugar in bread. Most breads have sugar. There's sugar in tomato sauce, you know. So no, but eat less. That's what we would advise. Cut down on your fat, and ideally eat the good fats. So we go for the oils and such like, not the high butters and such. What's your salt intake? And again, if you avoid processed foods, that's the first thing you can do to reduce your salt intake. It's much, much higher on processed foods. Now, look at all those, what I've said there. Aren't they things we should all be doing? And this is something, again, very important when you're talking with your patients. They don't need a special diet or because they have diabetes. What they need is a healthy diet. And it's a healthy diet the whole family should be following. And that's what we would always encourage. Because otherwise you'll have the, I brought herself in, as the patient would tell me, because she does all the cooking. And I'm going, no, you have a responsibility too. It's as much your diet as hers. The control alcohol intake, I think, is interesting. And it's quite, now there's a number of reasons we talk about controlling alcohol intake. One, it's very, very high in calories. It's alcohol itself, so you tend to put on weight. And it's the alcohol, not the, if you're talking about the beer, it's the actual alcohol percentage that has the high calories. Very few people tend to know how much is recommended daily intake. We talk about 11 units a week for a woman, 14 for a man. In the UK, they've actually changed that now, and they're going for a total of 14 for everybody. And I imagine we're going to follow suit. A unit of alcohol is 125 mils of wine, a shot of spirits, or a half pint. So it's not a lot. It's quite easy to actually make up to your to get your recommended allowance. And we always say it's a recommended allowance, it's not a target. And it shouldn't all be taken on one night. So these are good things. And finally, I would say avoid special diabetic foods. Diabetic foods tend to be very, very, if you look at the things like the chocolates and that, they tend to be very high in fat. They also usually have nearly as many calories, they'll just use a different sweetener. Some of them use sorbitol. Now the problem about sorbitol is too high an intake of sorbitol gives you diarrhea. I remember looking at one stage in the hospital, and they had it on sale in the shop, but they stopped afterwards first. And they had diabetic chocolate, as it was called. The recommended intake or daily allowance of sorbitol would have been 2 squares of that chocolate. Now, many of us, if you open a bar of chocolate, would have 2 squares and no more. So these are factors to bear in mind. Avoid them, and we would always say that, avoid them. Look for healthy foods if you must, and go for the, zero sugar yogurts and things like that, but you don't avoid the diabetic foods. The first oral treatment is a healthy eating plan. Then, as I say, we'll add in the medications. And finally, we'll add in the insulin if it's needed. But as I said, it's progressive disease. And quite often, I can start off and you'll manage well on a healthy diet. And then I may have to add in tablets after a year or two. And I may end up, that doesn't mean the patient has changed or is doing things wrong. It just means the disease is progressive. And it's important to remember that, because I've seen patients, not quite attacked, but certainly being given out to by the healthcare worker. Because why aren't you looking after your diabetes? They are looking after diabetes. Their just needs and requirements have changed. I'm only putting that slide up. It's an example of some of the medications that are available. They always say when you're giving medications, look up what's available and the latest information on it. We're constantly working to develop new things in this. I haven't got that out of there. But it's just an example of what's there. Now, this is what I really want to focus on. This is the reason we get excited about diabetes. It's the complications. Someone said, it's a pity it's not a painful disease. It's not because you can have diabetes, you can ignore it, as I've had patients do on me for a number of years. But the thing is, it has a habit of catching up. Because if you don't look after your diabetes, you will develop complications. And these are the complications. Retinopathy, which can lead to blindness, nephropathy, which will lead to renal failure, neuropathy, which is nerve damage, can lead to foot ulcers, amputations, and autonomic dysfunction, including sexual dysfunction. People with diabetes also have an increased risk of cardiovascular, peripheral vascular, and cerebrovascular disease. So I'd always say it's a very holistic disease. It gets you on all fronts. And you think of your cohort of patients and those who have diabetes, and I would put money on it that a number of them have these complications already. And what we want to do, ideally prevent them, but if we have them, we need to identify them early and treat them well to make sure they don't get worse. So the first complication of diabetes, we say, is hypoglycemia. And it's something, if you ask a group, what's the commonest complication? It only affects people with who are on insulin or on certain medications, such as sulfonylureas. Things like metformin and glucophage, you don't go hypo on that, but you can. And as Angela said, it's a huge issue. Now, there's a number of studies being done that's quite interesting. And I'm talking not even patients with mental health issues, but patients who just attend me for diabetes and no other complaints. If you don't ask, have they had problems with hypos, they won't tell you. You don't know why, but they won't do it. So you can imagine that it really does apply to your diabetes in general with people with mental health issues. If you don't ask, you're not going to hear, and they just think it wasn't that important really. And that's how they rationalize it back to themselves. If you have a person who you think may be hypo, and I will talk about the symptoms, first give them fast-acting, ideally check their blood sugars, but if in doubt, give fast-acting glucose in liquid form. And fast-acting glucose is, not something with fat in it. They look for biscuits. I need something that'll act quickly, and ideally glucose and Lucozade works quite well. Any of the Fantas that provide, they're not the sugar-free ones, will work quite well. If they're not capable, if they're unconscious and not capable of taking oral glucose, we can give glucagon, but we don't do that very often. They need to be written up first. Chance of having someone handy to give IV glucose is slim. Ideally, we'd say if you get them back, if I give them fast-acting glucose and they come around, I would tend to give them longer-acting glucose and something more solid to eat, because I've spiked them up with fast-acting glucose, but it tends to drop fairly fast. And ideally, look for the cause. They may need further education. The symptoms of hyperglycemia of low blood sugar, such as sweating, anxiety, tremor, all these things, and there's a length of them. There's too many symptoms to mention. But the thing is, you can get those in anxiety disorders as well. So how do you know what it is? Yeah. And that's something to bear in mind. The thing is, if you have a lot of hypoglycemia, it can dampen down your ability to recognize it. And then people fail to be able to act with it. And even if they do recognize it, they can't organize their thoughts because their sugars are going down. It happens as your blood sugars drop. There was a very interesting study done in the UK. And what they did was they took groups of healthy volunteers, they split them in two. They took 10 of them down to a blood sugar of 4 with glucose clamp, and then brought them back up to normal and set them off. The other group, they brought the other 10, they brought them down with a glucose clamp to 2.8 and then brought them back up to normal blood sugar and let them off. They repeated that test 8 weeks later, and they found that the people who have been brought down to 2.8 on the first test were slower to show signs of hypoglycemia. So it's an interesting, and that was healthy volunteers, only one study, but they have repeated since. So bear in mind, we don't want them going hypo regularly. Retinopathy is the eye disease. It's the commonest cause of blindness in the working age population. Now, it causes visual loss. And what happens is we have little blood vessels at the back of the eye, and because of high blood sugars, circulation gets compromised and the nutrients don't get through on oxygen. It can be diagnosed with fundus photography, and we screen for this now, and it doesn't matter who you are, what other conditions you have, mental health or any other conditions. If you have diabetes, you're from the age of 12 onwards, you're entitled to attend for your retinopathy screening once a year. There's centres in Dublin and Cork, can't remember where the other ones are around the country, but your patients are entitled to go and make sure they are going. And I look for microaneurysms, hemorrhages, or hard NCDS. Can you imagine the impact losing your sight would have? On a day-to-day basis, if you couldn't, and it's simple things. How do you know a cup of tea is full when you pour it? You look at it. So even things like that, look at the impact it would have. we have found we can prevent it, retinopathy developing, or indeed slow it down with good control. So I need to diagnose mindfully, I can do that. These are what the back of the eye looks like. Normal retina, there, and my macula, my optic disc, and nice clear blood vessels. This is where I am. Look up, I have hemorrhages. I have my little bulging aneurysms. I have my cotton wool spots all over the place. I want to avoid that. Now we do treat it. If you get it, I can treat it. We seal it off. We'll actually do, but the thing is, I can't improve. I can't stop. You know, if you have it, you have it. And the thing is, poor eyesight is not an indication of retinopathy. We all tend to need glasses as we get older, and that's your optician's job. Go and get it checked. If you're, if it's impacting on your sight, it's well advanced with it. Neuropathy or nerve damage, and we talk about the autonomic ones, which are my automatic ones, and my peripheral ones, and it can affect both, and indeed the entrapment ones can affect. Autonomic ones, these are the ones that happen, you know, I talk about the postural hypertension. I get up, my blood pressure doesn't get up with me because I have autonomic nerve damage. Abnormal sweating, gastroparesis, which is vomiting, and I mean vomiting. When you think of it, if I have diabetes and I'm telling you to eat regularly and then you're throwing up for no good reason, we have ended up having to put in pegs because of gastroparesis. Similarly, constipation, diarrhea, we will do colostomies and ileostomies for this. Erectile dysfunction, which is major issue for the patients, and then is it due to their medication? And bear in mind, some of their psychiatric medications can impact on this as well. And of course, it's Ireland, so we'd never ask a patient. Not mind. You know, these are major things for our patients. We need, and they're only part of the body. We need to ask. Peripheral neuropathies, loss of sensation in hands and feet. So therefore, if you do hurt them, you don't realize it because you don't feel it. Neurogenic pain, nerve pains, which are horrendous. And they tend to be particularly at night. You'll tend to get this on contact sensitivity. They find it impossible to have things near their legs or their feet at all. And they need bed cages. It's very, very difficult and very difficult enough to treat. Good control helps. The entrapment neuropathies, carpal tunnel syndrome is one. Tend to see that you get loss of sensation in your two fingers. It will respond to surgery with it. But can you imagine your patient with mental health problems? They have enough problems, they don't need these as well. And if we as nurses, by even talking about it and asking about them, can identify them earlier and therefore help prevent them or indeed stop them progressing, it is a huge benefit to your patients. This is that's an example of Charcot's joint. See the abnormal foot flat here? And that foot, because they had no sensation of pain, damaged the foot and didn't feel it, so kept trotting around and walking around on it. This is, I'm trying to measure microfilaments. I'm just seeing what they can feel. You get the patient to close their eyes and see what they can feel. And that's grand if you've that bit of kit, but you can try to ask them to close their eyes and see will they feel you touching it with a bit of cotton wool. Very simple test to do. Renal disease. And renal disease secondary to diabetes. It does affect both the glomerulus and the tubular elements of the kidney. If you have renal disease, I tend to find they tend to have hypertension and quite often cardiovascular disease. And what it starts with is a loss of microalbumin. Now the thing is, we won't pick up microalbumin routinely on a dipstick, but I will get it and I will actually, it's one thing we do every year among the tests. I do cholesterol, triglycerides and all that every year for my patients. I'll also check for microalbumin. And it's a simple, early morning sample of urine off to the lab and they'll check for that. If it's positive, I'll then do a 24-hour collection. Because if I don't get it, if I get it then, I can give ACE inhibitors and that and it'll help reduce it. But if I don't stop it then, it'll progress onto frank protein and in the end they'll end up renal failure. And you know yourself, patients with mental health issues are not going to be high on the list for a renal transplant. They're just, so it's not fair. Patients with mental health issues need it even more. Need care on this, so much more. And as I say, that's my little shriveled up little kidney, which I'll get. secondary to my diabetes potentially. Macrovascular disease. Now, microvascular disease, sorry, peripheral vascular disease. This is where the circulation, particularly the circulation in the small vessels, gets compromised because it's somewhat similar to the eyes, but because I'm sort of blocking it with the high sugars, gets to be an issue. Now, the thing is, peripheral vascular disease, very common in diabetes, very common in smoking. People are smoking, it's a complication of smoking as well. What do patients with mental health issues quite often do? Apart from having diabetes, they smoke. If you do both, you're doubling your chances of getting it. Ideally, we prevent it. We recommend stop smoking and we recommend good control. This is why I want them to stop it. This is gangrene. And what happens when you think about it? If I have poor circulation and I perhaps have some neuropathy, so I didn't notice that I had the foot shoe was too tight in my foot and I got a bit of an ulcer. And then I have poor circulation, so I can't, it won't heal. This is what I'll end up with. Now, the best way to prevent it is by looking at the feet. Now, I say this to patients and they go, what? But think of it yourself. When was the last time you looked at the sole of your foot? And I'm assuming you're all fit, healthy and able. So what hope have your patients who may be a bit compromised through lack of motivation, perhaps if they're going through a bad phase, through physical ability, because if you're older or heavier, it's more difficult to look at your foot. We'll actually recommend they get a mirror and look at it that way. But these are all factors which impact. Prevention is the best thing. Your patients, a number of them will be medical card holders, are entitled to see a chiropodist or podiatrist. Make sure they do. Or don't be afraid to look at the feet themselves yourself when they're in with you. The advantage of doing this by slide is you can't smell this. Unfortunately, it's a very unpleasant smell. It's rotting flesh. The treatment, by the way, for gangrene like that is amputation. That's what we treat, how we treat it. So we would normally take off the foot, and then of course sometimes that doesn't heal. So then we'll do a below knee, and then if that doesn't heal, we do above knee. And you know, it's creeping amputation. I used to hate them, but ideally, the annoying thing is can be prevented with it. Macrovascular disease, another complication which is very common, unfortunately, with my patients. We tend to see high cholesterols and triglycerides in patients with diabetes, and we tend to see hypertension. Both these are risk factors for macrovascular and cardiovascular disease. So I'm going to see more people having heart attacks, more people having strokes, and that is a fact of life. Part of the problem with complications is, and we have had people come in with silent MIs, as we call them, where they didn't actually feel the pain through neuropathies, and they present with a thing. The other problem, we'll often have people presenting with a heart attack, and that's when their diabetes is diagnosed. And it's part of the problem, as I say, about diabetes, the fact it can be such a subtle disease and be there for a number of time, and we just blame it because we're getting older and we're getting slower and things like that, or it's because you're on your psychotropic medication, that's why you're slowing down. It could be diabetes. This is the prevalence of tissue damage at diagnosis. 4% were showing frank proteinuria, 8% loss of reflexes, so that indicates damage, 12% had absent foot pulses, which indicates peripheral vascular disease, 17% had cardiovascular disease, and 18% had eye damage. And many of them also have other illnesses, chronic illnesses, such as mental health, serious mental health issues. And that's what we want to avoid. Now, you are lucky, your patients should be lucky insofar as they are involved in healthcare. They are being seen regularly by healthcare workers such as yourself. And we have a responsibility to look for and check for chronic illnesses such as diabetes. So as if they had any of these, I'd pick them up early. Ideally, I treat them and prevent them getting worse. But maybe I could even pick them up before they have. That's what we want to do. Treatment is by education. We talk about an annual review. And this is something I know, and it's like ties in well what Angela was talking about, physical screening. You do your cholesterol, triglycerides anyway. That's part of what you do. You do your weight, things like that, the blood pressure. These are things I routinely check on patients at least once a year on patients with diabetes. What you can do then is if they have diabetes, I'd add in the retinopathy screen. I do that. And I would also add in something, a HbA1c check for their diabetes control. But you're doing it, if you're doing the physical screen, it's only one or two extra little things to make sure they have a full annual review of their diabetes as well. We would always say they need to be seen then by someone who will check for their reflexes, check for the foot pulses and things like that. And ideally that see that with all the results. And that's what, so if you're doing your physical screening, you're halfway there, or more than in fact, for your people with diabetes. And look, could you imagine if you could stop one of your patients going blind or stop one of them losing a foot? Think how good that would be. As I say, we aim for good diabetes control. It reduces the incidence of diabetes, of complications, or it stops them getting worse. We treat symptoms. So if you have high blood pressure, we'll treat it. If you have high cholesterol, we'll give you statins. We do that. The other thing we always say, remember patients have multiple complications. And I will say, God forgive me, some of the medics are very bad at this. I remember being up with a patient who was in having had an MI, and they were admitted, and I was up with them, and I was there when the cardiologist came to do rounds and arrived around, and he was going, you're going to have to sort this out. You need to lose a bit of weight. I want to see you getting out and getting more active. And I looked at him and I said, but the patient only has one leg. You know, and the thing is, we need to look at the whole patient. It's why I always think it's good being with the mental health nurse. You always see the whole patient. With diabetes, we have to see the whole patient, and that's the good thing. And we can treat, unfortunately, what may be more than one complication. We have at least 5.6% of the, this is our Canavan study, of the Irish population of diabetes. So you have them in your cohort of patients. They're on the increase. It's one of our greatest health challenges this century. We spent a fortune on it. And we spent, particularly on complications. So we need to look after this diabetes thing. We need to stop it developing, ideally, by treating them. And that's where we focus more on next week. But if they do have it, we need to get it early. And this is what I mean. It's a team. And you know yourselves, your patients aren't always the greatest at coming for their physical checkup in the hospital to have their attendance diabetes. Maybe because they have other problems at the time or other challenges. If that's the case, it's even more important that you are able to talk to them about it, remember to talk to them. I'm a great believer in have a good link with your diabetes nurse specialist. Most patients are either linked with a diabetes nurse specialist in the hospital, or they're linked with the community diabetes nurse specialist, which we're increasingly having. There's more of them around, so they work with the practices. So get in contact with those and see what you can do. They're quite good about further education for your patient and things like that. And it's back to this idea, because you mention it, your patient sees it as more important, and not like, as Angela was saying, where the nurse never mentioned it, so therefore they didn't think it counted. Smoking is something we're dead against from the point of view of diabetes. And just because you have mental health illness and smoke doesn't mean you don't need or want to give it up. How often, and it's us making assumptions quite wrongly at times that it's all they have in life. That doesn't mean they don't want to feel better. And I always a great believer, it's something they may be able to get control over. So it's important that they get that opportunity. And the other thing is that even if they start and it doesn't work, doesn't mean they can't start again. So I'm a strong believer encouraging people to stop smoking. And the fact they have mental health illness doesn't mean they shouldn't be encouraged to smoke. There is a lot of support out there for stopping smoking, and we use it. We need to work together as a team in relation to these things. These are factors which are modifiable by education, but they are also impacted very much by your psychotropic medications. So we need to bear that in mind. It's what we'll talk about next. Setting achievable goals, very, very important. If you're overweight, like if I have BMI of 40, there's no point in someone saying, well, I want you down to BMI of 25 now within 3 months or 6 months. I wouldn't be able for that, whether I had or hadn't mental health issues. You have to set achievable goals, and we have proven that people who become fitter, even if they're still overweight, are a lot healthier. Insulin resistance, if it's a factor, and it is quite often in type 2 patients, we will tailor medications to treat that and work with that. So we bear that in mind. But we need to know about what's on. How many of you would know what diabetes medications your patients were on, or would you just know they're on them? Something we need to have better exchange of information, I would always say. Yeah. It tends to push up, some psychotropic medications tend to push the sugars up more, and it's very, very important to bear this in mind. It's not a problem. I can treat it. I may need to adjust their diabetes medication, so if there's psychotropic medications, I adjust it. And equally so, if they're reduced, I may need to reduce the diabetes medications so as they don't get hyperglycemia or whatever. And it's the importance of working together and looking at the bigger picture. And obviously the high lipids, which unfortunately can and do happen, but they're treatable with statins. And that's it. And if one statin doesn't work, we have a huge range of statins. So we can offer other ones to patients. Because you'll find people going, oh, I can't take them, they don't make me feel right, they give me aches and pains. That's grand, that one did. I've lots more I can try. So maybe we just need to try them. And that's an important factor to remember. These are things I can work with and I can help improve from our side. The patient does their bit too, but it's important that we work together. As I say, we found that lifestyle changes can prevent or delay the onset of type 2 diabetes among those with, particularly those with impaired glucose tolerance or impaired fasting glucose. It's even more important that we do that with patients with mental health issues. And you know yourself, if they're physically active, how that can improve their mental health as well. As I say, we have a diabetes prevention program that we're running in certain parts of the country, not enough of it, but it is available. It's available in the northeast here. We have it down in the south as well. And I'd have a list of those for you next week as well when we're on. But there's no reason why your patients can't log into that, can't start with those, and it's to be recommended. As I say, we need the literature to back up what we're saying. Yeah. And it is available to support what we're saying. Bear in mind, if you're making a case and you have your hands full, it's not that you're sitting there twiddling your thumbs looking for things to do. You are up to your eyes with work and managing and supporting your patients. Arguments such as these and this literature can support you making a case for having even half an extra nurse or half a dietitian or half a, this is what works. It's what they will listen to. We need these included. We need to help motivational interventions. You know yourself, how often have we said, I always said, 1st of January, I'm going on diet, I'm going to get out, be more active, I'm going to eat better, not drinking. How long does that last? And that's us, healthy. So it's even harder for your patients. And bear that in mind. We all need to be motivated at times. Stress management strategies. It is quite stressful managing your diabetes. If you have complications, it adds to it. Coping skills training. These will work both on your chronic illness, such as your diabetes or whatever, and also on your mental health. The support is essential. An active case management, because as I said, it's a team. The patient is the most important part of the team, but we need the whole team involved. As I say, you're a nurse. Diabetes is a nasty, or maybe there's a dietitian there. Sorry, apologies if I didn't include you. You can make a difference. There is a huge instance of diabetes among those with mental health issues. And working with those patients can make a huge difference and can have a huge impact. It can help them manage their illness better and keep managing it. But I have to involve them and include them. So I think that's all I want to say. I'm going to hand over to Angela now, and we can take any questions or answers.
Thank you. Yeah, no, thank you, Sheila. That was really enlightening. I every time I hear these slides, I'm taken in by them, because it's such a huge illness that has such an impact on people's lives, you know. So I think hearing it is all over again is really important for us, especially for us as mental health nurses, because I know and you know out there that a lot of our patients actually are already diagnosed with type 2 diabetes. Unfortunately, there is a divide, Sheila, between primary care, their GP care, and us as secondary care providers. And a lot of the time, the GP might put a patient on metformin, but we may not be familiar, or we may not even be told what medication they're on, because psychiatrists are more inclined to just prescribe psychiatric medication. So there can be a bit of a divide between primary and secondary care, and we definitely need a shared care approach. And that was highlighted by one of the attendees here today. You know, we do know, though, there's things we can do as nurses, because we know that effective control of type 2 diabetes, it requires the patient to have self-management skills, and they don't get that from a GP. They definitely don't get that on a 5 or 10 minute consultation with a GP, but they do get that from their interaction with us when they come to our depot clinics or our classroom clinics or in our high support hostels, that we can teach them more self-management skills, and we can teach them more about managing all of their medications and deciding which medications, you know, knowing their medications and knowing why they're taking them. We can also do a lot of work, as you said, in encouraging a healthy diet, and a diet that's specifically tailored for someone with diabetes. And you're right, we can also do a lot of work with regards to exercise, walking and such like, and we will talk about them next week. The important thing I got from this also was the importance of the foot care, Sheila. I think a lot of us probably as mental health nurses don't, you know, we're not batting patients so much nowadays as we did in the past, so we may not be aware of what sort of condition their feet are in. And you're right, the patient themselves may physically not be able to look at their feet. And that was interesting that you suggested maybe getting them to use a mirror to see their foot, because that might help in identifying if they've got issues in their feet that might lead to, as you say, a gangrene or something very serious. So that's important. You know, the retinopathy tests, I mean, I don't know how many of our patients have gone for them. We have no registrar to say who has had their screening tests, and you know, we'll talk about that next week when we talk about cancer screening and all this, the free screening programs that we have in Ireland. We probably need to know that as well, and that might be something we might take for our patient in our care. If we have a patient on our caseload or in our high support hostel or in our acute unit, that we might be able to check with them to see, have they gone for their eye test? Yeah. Or have they been attending maybe a diabetic nurse specialist at some stage and had their feet checked? Or are they going to a chiropodist or a podiatrist? So these are little things that we might be able to do that would be helpful as mental health nurses. You know, I mean, that literature that you referred to earlier talked about this motivational interventions, and a lot of those motivational interventions are on the MEC, making every contact count. And it's not that we're taking over diabetic care. I mean, in fairness, we have enough work to do without taking over the whole remit of diabetic care, but we can use some of our time when we're meeting clients to do that short conversation that's encouraged in MEC that we'll talk about, because you know, we've done the MEC training, we know the importance of it, and we hope that maybe you would use your time with your client when you're sitting with them going through their blood pressure or going through their BMI, that you also talk about maybe some motivational things about diet and exercise, and just checking in to see, you know, what exact care they're given to their diabetes. We also will have to go and do maybe something about the stress management issue, because that latest literature that I looked at from Canada, which was the 2021, no, sorry, the Dutch one, the 2020 literature, which says mental health professionals never mention my diabetes. They don't care about it. So, well, I mean, at this stage, we're saying, yeah, we do care about it. So they're recommending that we maybe look at some of the emotional distress that they have around their diabetes and the challenging aspects that they have. And we can do that because we're good at maybe stress management. We know how to do stress management. We know how to calm an anxious patient or a distressed patient. So perhaps we can use some of our stress management strategies around the area that they find most challenging, around the area of managing their diabetes, around the worries they have about hypoglycemia, or about the worries they might have about going on insulin. So we can use the skills we already have, and we can teach them some coping skills, because we're good at that too. So we have loads of already with loads of interventions and strategies that we can use with our diabetic patients. It's not that we want to learn something new, but it's just bringing about awareness that we will be not afraid, as the literature says, to ask the question or to talk to the patient about it, that we're, you know, more aware of it and that we're willing to get into dialogue about it. I notice now on the chat, I'm not so sure how many of you have patients already who have type 2 diabetes. I'm trying to kind of get a feel from you as to how many of them are prescribed the metformin. To me, I did a review 2 years ago in one of our North County Dublin areas, and a lot of the patients I looked at for metabolic syndrome were already being diagnosed metformin. So even when we looked at their blood results, the glucose test, when we looked at the fasting glucose, they were within normal remit, but that was probably because they were already on metformin, which was prescribed by their GP. So when we're looking at blood results that come back for patients, we also need to know, is the diabetes under control because they're on metformin, and is the lipids low because they're on Lipitor, so we kind of have to get more information on the physical drugs that the client are getting when we're doing our metabolic screening. That would be important for us, I think. If anyone has any questions at all related to this, please feel free. Now is the chance to get into the chat box. We have about 5 or 10 minutes that we can address any issues that you might have specific to your. I know somebody mentioned the hemoglobin test for as a reliable indicator last week. Did you want to go back over that again today, Sheila?
Well, the other thing to mention is, yes, it is. The HbA1c is a blood test we can do. You don't have to fast for it. It gives you an indication of what blood diabetes control has been for the last 4 to 6 weeks. And it's quite a useful test as just to give you an idea how well the diabetes is being managed.
Yeah.
Increasingly, we're finding patients are being given sensors now. Now, it was quite interesting. I was talking to a mental health nurse recently, and he was saying, yeah, got a sensor, it was great. And then the patient thought somebody was trying to track him. So he kept taking it out. And this is the problem. The patient went through a bad phase. And the one thing I would say, and you talk about the lack of shared care in this, we don't have enough of them, but we do have community diabetes nurse specialists. And I would say, find out, is there one around your area of practice? Because they're very handy people to have in, to talk a bit about diabetes, to do maybe an education session with your patients when they're in, and just to keep the patients motivated and working with it. There is a few community dietitians, but they're even more scarce than the community diabetes nurse specialists. So you might be harder to find them. But find out what's available in your area and use it. As you say, you have more than enough on your plate. You don't need extra work, but it can be sometimes handy to use these people to help deliver the message and make sure the patient is being well looked after. And we all learn from these sort of sessions. I will say that. You learn from, if the nurse comes in and starts talking, you'd be surprised how much you'll pick up yourself with it.
Absolutely.
There is a few of them around.
Absolutely. Yeah. Absolutely. Yeah. For sure. Look, we will be maybe referring a little bit again to maybe diabetes, but not so much. We're going to be really focusing on all of the interventions that we can use now for physical health next week, and it will be around the screening, but more about intervening, what we can do to help, with the whole area of not just diabetic care, but people with any chronic illness, and particularly around the whole area of metabolic syndrome. And we'll be looking at people who have cardiovascular issues, and maybe people who have diabetes, also people with high dyslipidemia, and people who have probably even people who suffer from respiratory diseases and illnesses around asthma and that. So it'll be all the whole area of what we can do interventions around people with physical health and what interventions we can offer them. And they're quite unique because these people have mental illness as well. So we have to tailor our approach to our client, and you know, that's something that we can talk about a good bit about next week. If anybody is interested in anything specific around that area, feel free to, you know, let us know in the text box if there's something particular you want from that session. That would be great. That would help us. Okay. Are we okay there, Sheila? Yeah, we have a date there for the 9th of December, which is next Wednesday, I think, yes. Yeah, next Wednesday, yeah. And the time is 2 o'clock. So I don't know, I hope you're free. I hope you have no clinic appointments at 2 o'clock next Wednesday and that you're able to make it from 2 to 3:30. That would be brilliant. We'd really appreciate it. And we'll tie it up together. We'll tie up last week's session, this week's session, and then we'll try and give you some take-home messages and things that might work for you in your practice area for next week. Yeah. All right.
That sounds wonderful. You've taken all my lines. I was going
Oh dear.
I was going to tell them about next week. So listen, Angela has taken all my lines. She said it better than I could. And again, I've learned, even though I'm a general nurse by background, I learned new things again today about the diabetes and its management. So always useful to get fresh updates. So you have a few minutes. If anybody wants to pop in questions, now is your chance. And again, you have the opportunity, as Angela said, to be back next week for the physical health screening for people with mental health illness, where they'll look at the, you know, how things are implemented, and that hopefully will give you kind of wrap up these. This will be the third of these 3 sessions on the physical assessment piece. There was 28 of you online, which is marvellous. We're absolutely delighted that so many of you were there, and you're hopefully benefiting from these and able to take some of the knowledge back, obviously, to your services, to your colleagues, and more importantly, that it helps you with the management of your clients and your service users. So I'm going to give you a minute. If there's anything to pop in, I don't want to delay you, and we know it's coming up to lunchtime. Yeah. So if there's any questions, feel free to pop them in now. And if not, we will see you next Wednesday for our last one for this year. And hopefully as many of you as possible now will be back again. And tell your friends as well, obviously. Aisling, do you want to say hello while they're just, there's no questions coming onto the screen. So I think
I'm seeing questions in the Q&A.
Oh,
do
great.
Specialists give brief management plans? Unfortunately, they don't. We don't give management plans for patients. We will try and give targets that they would work to, but we don't tend to hand out a plan as such with them. And that's why I would like to see better links, so that you as a mental health nurse or care worker could ring the GP practice nurse and go, listen, when the diabetes nurse community diabetes nurse specialist is in next week, would you ever give them just a few goals or a few goals to work with? And it would make it so much easier but that's something we're not doing at the moment. Occasionally you will find a patient, will have a plan, but that tends to be, it's not a routine thing, it's more a once-off thing.
Yeah. Sheila, there's a question there about ECGs. Are they mandatory for patients with diabetes, Sheila?
No,
I didn't.
We do like to do them routinely as part of your annual review, but then it depends where you're living and what you're doing, whether or not it will be done. And quite often it wouldn't be done routinely if you're attending your GP for your monitoring.
Yeah. It's more in line with people with psychiatric issues who might be on a drug called clozapine who would have the ECG, but not necessarily for diabetic patients. Yeah, I understand. Okay. That's fine. That's good. Okay.
There's other comments up along. Have you? That's what I. Are they kind of addressed, Sheila and Angela? There's just comments. I know. See, you were the guest exam, so a lot of them I think have been answered going along.
Yeah.
Isn't that what I'm? Yeah. That's what I kind of am looking at.
Yeah, I was looking at that, about the shared care approach and about what we can do, you know, as in our remit as mental health nurses. You know, we can't take over the whole remit of diabetes, but we can do certain amount with our motivational interview. And, you know, when we use our MEC effectively, it can work really well for us, you know, and in teaching maybe stress management strategies for patients who are distressed by it and coping skills. So we kind of have touched on some of that. that in our talk, I think. You know, we can certainly back over that again.
This is where you as a nurse or as a healthcare worker need to reach out and make a contact so that it becomes part of practice, that there is a link there. Because at the moment we do tend to operate in parallel lines far too often, you know, and we don't talk to those who care about who care about the mental health issues or that. And as I say, I used to even find it myself where the cardiac people wouldn't talk to the renal people who wouldn't, you know, so you can, it's even worse now that we're in the community more. So I think, and that's what we can do it. We can set up these practices. That's the advantage of where we've gone now with our training and that we can lead on these things and set it up as a routine, that it is part of it, and be it once a month or whatever, that there's a liaison meeting with the community diabetes nurse specialist who will actually discuss, you know.
Great.
Yeah.
So if you're happy, no, I don't think any other questions have come in there since.
Look, I have a few
some
publications.
comments.
And there's some publications here that I can make available if anybody's interested in them. You know, I have these particular publications, particularly systematic review, and also listen to the patients. We talk a lot about the patient's narrative nowadays. We're very much into service user empowerment, but let's not just pay lip service. Let's actually listen to what patients are saying. And these are evidence of patients' words, of what their distress is. So maybe by showing the evidence of what the patient's saying, maybe that will influence how we deliver care going forward. So I can make these articles available to anyone that wants them, because that's the evidence that's coming forward now in the last year or two from what we are finding out, you know, about diabetic care in people with severe mental illness. So we have the evidence there. So maybe share it.
We're happy to email them out to everybody with their search, Angela, if that works. That'd be great.
I just put up the diagnosis and classification from WHO, but also a little checklist from the HSE about what to do for type 2 diabetes, and which we're up there as well.
Great.
Great.
So I'm going to hand over to Aisling for the finals, and we'll see you all next week, please God.
Thank you.
Thank you so much, Sheila, and thank you also, Angela. I actually wish I was learning all of this subject again, because there's so much more knowledge. Certainly gone back, and it's a while since I trained as a nurse, but my goodness, I mean, there's a wealth of information, some of which we never touched on in our training, certainly. And I mean, it just really emphasizes the importance of continuous professional development, the importance of the spread of subjects of which we've encountered over the last few weeks, but indeed the depth of this particular subject. The fact we're taking it into 3 weeks, and I know from Angela and Sheila, we're only tipping the iceberg here, really, you know, but that's part of this whole initiative, really, is to kind of, obviously to learn, but also to develop, but to tease you into subjects that you may not have ever considered as part of being and that's not a judgment in a way, but that's the breadth of nursing at the moment. And indeed the way we, if we've learned anything from the last year in terms of the adaptability and the foundational program from which we train from, it's scalable, and we're capable of building within that. And certainly with fantastic experience and knowledge of Sheila and Angela, it makes it so much easier. So, I mean, I have to thank you truly. I have learned so much. I mean, the piece about Sheila, for me, actually, and Angela mentioned about feet and listening to our patients, you know, etc. That whole piece about pain and nerve pain and all of that. When you consider the challenges somebody might have who may have a mental health problem with nerve pain, feet problems, dietary issues, I mean, really and truly, we humans are remarkable, really, but I guess it's on us, and as much as we possibly can, to liaise with those who have the specialist knowledge if we don't have it ourselves, or use that collaborative approach. So thank you for even emphasising that whole piece for us, the holistic nature of ourselves, but indeed some of the resources are out there, and of course for your wonderful knowledge. So I'm truly grateful, and thank you on behalf of all our colleagues. We hope to see you all again next week, as Catherine says, for the third and final pre-Christmas webinar, and it would be great if you can join. And thank you for all the resources you've shared also. And again to Anya, who's in the who we don't see, but is keeping the show on the road. Thanks, Anya, again. So thank you, everybody, and enjoy your lunch, and we'll see you next week.
Thank you.
Goodbye.
Bye.
Bye-bye.